I'm Dr Jam
And I'm Dr Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hi Sally, good to see you again.
Hi Jam, so nice to see you too. How are you getting on? Good week so far?
Very good. Another day, another pod. I've just taken over looking after ward patients this week, so it's been a bit busier than normal, but it's been really interesting looking after different sorts of people at different stages of their journey, new diagnoses, a few patients having transplants. We also look after patients who are having CAR-T, which is for lymphoma at the moment. It's been really good, some challenging but really interesting patients and good discussions and a lovely team, which always really helps.
Well, that makes all the difference, doesn't it? Busy times. I know when I'm looking after the inpatients, it has its own rhythm, doesn't it? And you never know what's going to happen day after day. But actually that feeds in quite nicely, doesn't it, to what we wanted to talk to our listeners about today in terms of who on earth are all these people who make up the team when you come into hospital? So that's quite a nice intro really, Jam, isn't it, to what we wanted to explore today?
Who are the people involved in your care? And we're going to go through the journey that people may take if they go through the outpatient route, and then go off in different angles and directions because our patients are looked after in different settings and scenarios. Of course, there's outpatient care, inpatient in a hospital. Of course, a lot of care happens in the community as well with GPs. So yes, Sally, I'm really looking forward to talking about this over the next sort of 30 or 40 minutes.
At the very end of this pod, we're going to sort of do a mock sort of meeting where we make our decisions and figure out what we think is the right approach for each individual patient. So I'm really looking forward to that part of this pod. So when I was thinking about doing this podcast, I was trying to think of an analogy, how to explain this to someone, what's going on, because so much happens behind the scenes that people aren't cited on. And all I could think about is this. It may not feel like it in the NHS or wherever you're being looked after, that you've got everyone sort of running around trying to do these things behind the scenes, but actually that is what is happening. It's almost like you're a VIP, even though sometimes it may feel slightly different. And I think that's what we really want to talk about, is what people see day to day and that sort of teamwork around them. But Jam, what do you think?
It's like your average day, Sally, isn't it? You get woken up with a cup of tea in bed, breakfast is made for you. Your butler is waiting with freshly laundered clothes before you get driven to work. I mean, it's just like, you're a VIP at the center of the journey. Is that what you're saying?
Every day, honestly. And this evening, actually, I came home and my little boy, who's nearly 6, presented me with a gun, which makes rather rude sounds. So, yeah, that's my VIP treatment I have at home. So, as I'm sure you do too. But yes, indeed.
I think it's a lovely analogy. There are so many people who do slightly different things in a hospital, a clinic, in the community, in your home, but everyone has a defined role, and we all have to work together so effectively, and teamwork is so important to make sure that VIP, our patient, gets the best treatment and gets the best journey that they can.
Should we just kind of take someone through what happens when you're referred in to see a doctor in the hospital? So if I can kind of explain the scenario, Jam, and then maybe you can talk me through it really. You get a letter through the post one day saying you need to come to a clinic. That may be labelled as a haematology clinic, or it may even be labelled as an oncology clinic, which can be quite terrifying. And you turn up on the day, and who's the first person you tend to encounter during that visit? What would you say?
So hopefully you've got some good information that gets you to the right place. Unfortunately, parking can be a big issue. It certainly is in my hospital, and can really add to the levels of stress. It's often a receptionist who will check you in, get you to wait in the waiting area, which in themselves I think can be quite stressful places potentially. You see lots of other people. Everyone has their own story that is unfolding. And then your appointment has a time, and it will be an appointment to see a doctor, and the consultant is usually named on that letter. And it says you will be seeing Dr. Katari or Dr. Moore or one of their team. And I think that's a very good place to start. Sometimes before you're seen, you will be weighed and your height might be taken. And then one of the clinic staff or a healthcare assistant, who's like an assistant nurse, will take you through to the clinic room, and hopefully your appointment will be on time. So should we just expand on the type of doctor that someone might see really at any time point, whether it's a new appointment or a follow-up appointment?
I think this is really quite confusing, actually, because when you see that name in the letter, I think it's logical to assume you're going to see that person, but that's not always a given. I think when people talk about the NHS, they often can use a comparison almost with the army. There are sort of different grades of officer or workers within the army and the military, and similarly, albeit with perhaps a slightly different aim in the NHS. But everyone has to learn to be a doctor. Everyone has to train to be a doctor, even when they've passed all their medical school exams. They train in their specialist areas. And so sometimes when you come to clinic to see your specialist may be what we used to call a junior doctor. I think it's now called a doctor in training, or a registrar, or an SHO. All these words are used interchangeably, really. But what that basically describes is a doctor who is learning more about that specialist area under the supervision of a consultant team. So you may see a registrar, but I think in nearly all cases, that person is still a highly qualified doctor and very much knows an awful lot about the subject area, and almost always discusses every case with the consultant, who's more often than not in clinic with them as well. But you may almost see the consultant as well, who I guess is the person with that super specialist knowledge, who oversees the care of all the people who are coming into clinic today. And I guess that's our role, isn't it, Jam? That's what you and I do every day when we see people in outpatients.
If you do see a doctor that's not a consultant, they are directly supervised by one of us. And as you say, the cases are very carefully discussed, and it's the consultant that has the primary responsibility. And that's a really important point to make. So you will see a doctor of a consultant or a different grade, and information will be sought and history will be taken. Often patients will be examined as well. And on top of seeing the doctors, for example, if a diagnosis of myeloma has been made and that information has been parted, there is normally a nurse in the clinic appointment at the same time. So a specialist nurse, so a clinical nurse specialist. Sally, what's a clinical nurse specialist?
Yeah, really good question, because one thinks a nurse is, again, rather like a doctor. You imagine that they're all doing very similar roles, but a clinical nurse specialist, or a CNS as we tend to call them in short, is a nurse with, again, that specialist knowledge in that particular disease area. And what's so important about the clinical nurse specialists in haematology, and particularly in myeloma, is that they go on to be a very reliable point of contact should you have any queries going forward. And often the specialist nurses know the patients far better than we, the medical team, and can guide us through our decision making, and are able to tease out really crucial bits of information from those individuals, the patients or their families, which unfortunately we may or may not have time to pick up on in that 20-minute consultation when we first meet somebody. So they're a really brilliant port of call for additional information, but also for that patient when they leave clinic, and if there's something they've forgotten to say or another question, they can often contact that specialist nurse.
They provide written information about whatever disease has been diagnosed. They signpost to relevant charities that are also a huge wealth of information, such as Myeloma UK, and they are very contactable. And the way I often say it in clinic is that if someone has just been diagnosed with myeloma, sometimes things are emergencies and they need to be able to contact someone within minutes or hours. Sometimes they may have a query about something that can be answered by an email, and sometimes things can wait till the next appointment. And we ensure that they have those phone numbers for emergencies, the emails for questions that can't wait till the next appointment. And of course, when we newly diagnose people and people who are on regular treatment, we see people regularly. So there are always ways of getting the information that you need within a timely fashion.
Something I'd just like to add to that really is something that often goes through my mind is, when we see someone, I think it's so hard to take in a lot of the information. First of all, often it can feel like a little bit of a grilling from the doctor, because there's a lot of information we need to acquire to find out what's going on. And then we often flip that consultation or that conversation around, and then we share a lot of information, and it can feel pretty intense, I think it's fair to say. And I'm always concerned when someone leaves a conversation or a meeting with me that they may then go home and perhaps something I said or may have not quite phrased in a way that I wish to, or that may have been interpreted differently, will play on their mind. They'll wake up in the middle of the night thinking about it. And what I really don't want to happen is for that person to think, well, I can't disturb the doctor. That person is so busy, so I'm going to wait till my next appointment. But in that period of time of days or weeks, it might become really quite fretful or concerned or anxious about what's going on. And that's where the CNS can really come in, because you can just phone them up. No question is off limits. And they're that sort of friendly face to support you as you begin kind of this whole process.
Absolutely. And sometimes it's the second appointment after you've broken the news of a diagnosis that actually needs to be the longer appointment, because we've all seen it so many times, is that you say, I'm sorry, you've got cancer, you've got myeloma. Whatever is said after that just doesn't go in. People are often in a daze. I think I would be in a daze. And the way sometimes appointments work is that a new patient appointment, for example, may be somewhere between 30 and 45 minutes, depending on the hospital, maybe sometimes longer, but then follow-up appointments are shorter. But actually that second appointment needs to be much longer, because then people have had a bit of time, they've discussed it through with their loved ones, they've had the written information, they've maybe asked some questions along the way, and then they're more ready to really have a more detailed discussion about it. But everyone's different, and I think what we want to do is just make sure that we give people time where they need it and give the relevant information and contact details. And as you say, the clinical nurse specialist is an absolutely crucial part of the way in which cancer care is organised in the United Kingdom and globally, and they are an absolutely amazing resource. It was actually International Clinical Nurse Specialist Day just a few days ago, actually, and I saw some lovely photos all over social media, but they are absolutely wonderful. And we will be having more than one clinical nurse specialist on the pod over the next few months so they can talk about their work.
I salute all those nurses that we work with. We're very fortunate. But Jam, I want to ask you a question, just in terms of expectations, in terms of the people that we look after. And I think every hospital tries to share their workload differently. There's been a lot in the press of late about particularly people in the community, whatever they may have going on with them, wanting to see the same GP each time. And I wonder if sometimes the patients who come and see us in clinic would like to see the same consultant each time or the same registrar each time. And it's not always set up like that, is it? I wonder if you could just talk me through that process.
I think it does depend on different hospitals and how clinics are organised. But clearly doctors aren't there every week because they might be sick or be on holiday or be on study leave, attending courses. And that doesn't always coordinate when patients' appointments are. But in lots of cases, I think it's good practice for different people to see the same patient at different points in their journey, because we're all human and sometimes people pick up different things. And in a way, sometimes if you see different people, it's less likely that maybe things not get missed, but sometimes things get missed or people aren't thought about in the same way. But there's no doubt about it that the style of some doctors allied to the personality of some patients means that a very good therapeutic relationship is formed between two people. And that is something very important. And over the 10 years that we've been doing this, we've got many examples of that. So I think they're different models. But often if I've seen the same patient, say, for a couple of years, and I feel that things aren't quite right, or there's a difficult decision and I just need another pair of eyes on, I will say, can you just see my colleague this time? Because I think there are a few things here. Maybe I've got too used to seeing you and I'm looking at things with fresh eyes, I think can be very useful. I don't know, what do you think, Sal?
I completely agree. I think the benefit of sort of having that team approach is a team safety net. So that if, for example, as you said, if you had a particularly good relationship with a patient, but then you went on holiday and that patient needed to come to hospital, it's really important the rest of the team knows about that individual and about that family and understands what might be going on with them. Otherwise, you have a sort of a point of vulnerability or a potential point of error. And I think that's incredibly important. And the other thing to say is I wonder again, but I'd be really interested to see what the listeners think about this, is sometimes if you build those strong relationships with the patients, it can be really rewarding, hopefully for both parties. But then when you do need to see someone else, sometimes it might feel a little bit like, well, what have I done wrong today? Why aren't I seeing the doctor that I always see? And sometimes the system just simply can't accommodate that. So I think it is really important to work as a team, and that can often involve seeing lots of different people. But that's just how the services are set up. And I think it's tried and tested, really. I hope it works well for most people.
The haematologist, the doctor, we've talked about that interaction. Now, of course, there are other doctors involved in your care, and absolutely crucial doctors. I think we can call them back office. So there's other back office doctors that are extremely important. So radiologists, who are experts in analysing scans and a crucial part of the MDT meeting. So this thing called a multidisciplinary team meeting, where doctors with separate speciality and expertise come together to discuss the care of a patient. And at the end of the pod, me and Sally are going to do a mock MDT, and she's actually going to play multiple roles because Sally's a method actor. She's going to be a radiologist.
Indeed.
She's going to be a pathologist. So she's got a voice for every single part as well. So everyone, you need to stay on to listen to this because she's been practicing for about a week, and she's got a bit better, I'd say, but maybe not so much. But look, radiologists are amazingly important, and we're going to have a radiologist to talk about imaging on soon, but they're really important. And pathologists, we talked about pathologists a little bit in the What is Myeloma pod. They're experts at analysing tissue and making diagnoses on things like bone marrow biopsies and other biopsies. And along with the histopathologist, there are a lot of other expert scientists and people who work in laboratories who analyse proteins and blood counts and kidney function and liver function and all these kinds of things. And they're absolutely crucial parts of the back office that care would not work without them. So they are really, really important. And what about the other types of nurse, Sally?
Let's work from the premise that we have a patient with myeloma who needs treatment, and often the person administering that treatment, should they need to have it as an injection under the skin or into the vein, they often need to come into hospital for that treatment, and it will be a chemotherapy nurse who gives them that therapy. So these are nurses who are particularly trained in administering drugs which can target cancers. It's a very unique skill set, and it obviously you require a great deal of knowledge to do this, because the last thing you want to do is have an error and give someone, goodness, let's not even imagine it, but let's, for the sake of this podcast, someone the wrong drug or someone the wrong dose or at the wrong time, and you can just imagine it could be fraught with errors. And so our chemotherapy nurses are highly skilled in making sure the right person gets the right treatment at the right time when they need it, and it's safe to go ahead with the treatment. And so there are chemotherapy nurses, and another really important group of nurses, which I think people are often a little bit apprehensive about or slightly nervous about, I should say, are palliative care nurses.
So palliative care, historically, I think people have always thought about it as something that happened at the end of life. And it is part of that, but palliative care has become a big and brilliant speciality which is focused on symptom control. For a number of reasons, whether it's disease related or treatment related, our patients have many symptoms that need controlling. Every day in clinic, we are, of course, at the front of controlling symptoms, and a lot of what we do is symptom control. But palliative care doctors and nurses are absolute experts in minimizing symptoms such as pain or neuropathy. And they work in hospitals, but also sort of in the community. They go into people's homes. And for all the time that we have been treating myeloma, they've been absolutely crucial parts. And they're becoming a bigger part of what we do. And they're frankly just amazing, wonderful people that have such a huge impact on the care of people, whether they have cancer or heart failure or whatever condition it is. And we're lucky. We're all lucky to have them.
I couldn't agree more. I think an invaluable resource. And actually, I mean, it wasn't such a long time ago that for every person that was diagnosed with myeloma that I saw, that I would at that point be referring them to a member of the palliative care team, not because I thought that their outcome looked particularly poor. Indeed, I was then telling them that I would hope they'd be living with myeloma for many years, but rather to get that additional support and tap into the skill set of the palliative care nurses. So, no, brilliant team to work with. And sort of alongside that as well, another really vital group of individuals that are often quite scant in their availability, there aren't necessarily enough of them around, are psychology colleagues, because often the palliative care team can provide a significant amount of psychological support for patients and their relatives, and our psychology colleagues do that too. So they're not necessarily nurses per se, but they are specialists in managing the mental effects that can go hand in hand with a diagnosis of something like myeloma. And of course not everyone needs that input, but I think more often than not we could all stand to benefit from having someone to speak to and to help us cope with this changing situation. And so their role can often be very important indeed.
They're psychologists and psychiatrists, so there is a difference, and they're both important. So psychiatrists are trained medical doctors, and they have the ability to prescribe drugs that may be needed for depression, for example. And psychologists are usually not medically trained doctors, and they're experts on understanding the patterns of thinking. And over the last 10, 15 years, as the outcomes for so many cancers have improved, the roles of these doctors has actually expanded, because living with these conditions for longer has changed the type of way in which people need psychological and psychiatric support. And I think it's probably fair to say that the provision of these resources is different in different parts of the country, which is a problem. But I do think that when you go in, and if you feel like you need that support, again, the clinical nurse specialist or your consultant will be able to signpost you to where you can potentially access that kind of support.
As we said at the very beginning, really, if we think about that sort of VIP scenario, these people do exist in most hospitals, but sometimes you don't necessarily know you're there because there isn't time to flag problems or issues that have cropped up. What a patient might be quite shy to do so, or think it's not important. But so it's important to know that there may be other members of the team slightly out of sight that might be able to offer really important support and advice for everybody living with myeloma.
We were talking about the chemotherapy nurses and the safe delivery of chemotherapy. Another absolutely crucial role is the haematology pharmacist.
Yes.
A good pharmacist is worth their weight in gold. They make every day better. And I'm not just saying this because there may be some of our pharmacists listening, and I'm trying to, get away with getting other things prescribed or try. I'm not sucking up to you guys. Like, we honestly mean it. I mean, pharmacists are so important with chemotherapy and the safe delivery of chemotherapy. So what is their role, Sally? Because a lot of pharmacists, will have a lot of interaction with patients, either in the day unit or outpatients or on the ward. They are a brilliant and important part of our team.
Yeah, so their role, I mean, again, you could break this down into lots of different layers, but some of the treatments that we need to give to patients, the pharmacy team need to physically make. They make it up in their sort of, it's not really a laboratory, but in their back rooms, so to speak. Forgive me, pharmacists, if I've got my terminology wrong there.
Everyone's seen Breaking Bad, right? It's just like that.
Indeed.
It's just like that.
They help prepare the medicines, and they have to check that they've got the doses right and that the indication's right, meaning it's the right treatment for the right person at the right time. And importantly, they also check with about things like interactions. So the regular treatment a patient might be taking from their GP may not mix very well with the treatment that we want to give, or some of the supportive treatments that we want to give. So they're invaluable at essentially making sure the doctors aren't making mistakes or have thought of things that might not necessarily be at the forefront of their mind. And so again, they're another fantastic safety net in terms of making sure that actually in the process of trying to do good, you don't accidentally do harm, and they hopefully prevent that from happening. And they also can talk patients through when to take their treatments. If you take your treatment at a particular time of day, it might work better, it might not work so well, you might not get so many side effects, and so on and so forth. So they can provide that really invaluable, important important practical advice about what to do with all these tablets or injections or whatever they might be and how to cope with it all. Because it is pretty full on at the beginning, isn't it?
And it's not just the chemotherapy, which may be tablets or injections. It's various support medications that help you not get infections or protect your stomach or stop you getting blood clots. And organizing and understanding all of that. When do I take X and Y? Can I drink beforehand? Can I eat beforehand? There's some drugs or foods that you need to avoid. It can be quite complicated. Sometimes it's straightforward, and that's helpful to know as well. But they're so important at taking people through that. And they do a lot of education. Some treatments are completely oral, so tablet based now, and they will do a full education clinic appointment before starting a new round of oral treatment, for example. So they're really, really important. And they work with our colleagues, pharmacy technicians, who help the pharmacists arrange and coordinate the medication.
Vital members of the team. Thank you for all the hard work you do, pharmacists out there, if you're listening. And everyone else, of course. Let's not forget everybody else in the team. And then we sort of got the other sort of, again, slightly to the side, if that's the right expression, Jam, but the other team members. And I'm thinking particularly about our physiotherapy colleagues and our dietitian colleagues.
And often they get more involved on the inpatient side. Physiotherapists have very wide-ranging roles. Specifically in myeloma, it may be related to getting people moving again or working out how to get them moving and stronger in relationship to bone disease, for example, which often affects the spine and pelvis, and a number of our patients are older, so may have other reasons why they may not be able to get around. So they have myriad roles in encouraging movement safely. They are also involved, these are more sort of what we call chest physiotherapists. When people have a chest infection, for example, they're involved in trying to improve breathing, but they do so many things, and we're going to have a whole podcast with a physiotherapist and a myeloma specialist physiotherapist, because as you said, actually, Sally, on our last podcast, with people living so long now, and if they come in with bone disease, we want to find a way for them to be as strong and mobile as possible for as long as possible. So there is posture, movement, strength, flexibility, mobility, stuff that I should be doing in the gym every day as well, to be honest. And if you haven't got myeloma, you need to be thinking about those things. But gosh, if you have myeloma and it's affected your spine, for example, all of these things are so important. And a physiotherapist, and a properly trained physiotherapist, can really make such a difference and be a crucial part of your health moving forward.
I mean, I couldn't agree more. And I think it's also really important to say that what physiotherapists, what they can potentially offer to myeloma patients is a confidence to know that even if you have had an injury to your bone, you can still live your life. You can still, more often than not, continue to do what you did previously, unless you were a boxer and a rugby player, and different rules might apply. But by and large, they can just enable you to get stronger and healthier and more active in a way that you want to be, that's meaningful for you. So again, really important for quality of life, and they are brilliant at what they do, particularly the physiotherapists who have that specialist interest in myeloma, who really get it and know what's what with this disease.
You mentioned dietitians. Nutrition is, again, crucial in health and even more so in disease. It can be the disease or the treatments that can have significant effects on people's appetite or ability to eat. A simple example will be steroids can very significantly increase how much you want to eat, and you can find that weight has gone in the wrong direction. And some drugs will affect taste. Chemotherapy can stop you wanting to eat properly. So there are two ways in which dietitians can help. But the whole piece around nutrition, cancer and myeloma is something we're going to explore a lot in the coming months. So we look forward to discussing all of that in a lot more detail. Another role that we haven't mentioned, and again, they get more involved from our perspective in hospital, but they're very active in the community, are occupational therapists who, again, have a very, very important role. So Sally, what are OTs, as we often shorten their job title to?
Oh, it's often PTs and OTs, isn't it, when you're on the ward?
Yeah.
PTs,
do you think they mind? I hope they don't mind the shortening. It's a very medical thing to do, isn't it? To shorten everything to acronyms. But we love our OTs. They're brilliant. They have a very important role.
They really do, don't they? So OTs are occupational therapists. So what they're able to do, and they work across all disciplines, but particularly in the hospital, is look at what a person is able to do whilst you're in hospital, and look at how well adapted they may be to living their life when they get home. So for a classic example, not necessarily related to myeloma, maybe somebody comes in and they've fallen over, and they've obviously fallen over perhaps because they've tripped up on something, or it might be because they're a little bit weaker, or because they had an accident, whatever it might be. But in the process of having that fall, they may have lost confidence, or not feel so steady on their feet, or indeed not be so steady on their feet. And so your occupational therapist can look at that confidence and the support they've got at home. And sometimes, or frequently actually, they go into somebody's home and they look at, are the stairs too steep? Is there something they tripped up on? Do they need help with day-to-day life to make life easier and safer for them? Again, so they can carry on doing what they need to do. So there's brilliant practical bridge to living your life, particularly after you've been discharged from hospital, but not necessarily only when you've been discharged from hospital.
And it can be things as simple as putting a pair of shoes on, like something that has happened and your mobility and confidence has been affected, and you're worried that if you bend over, you might fall down or not even be able to get up again. And just the various contraptions and techniques and methods they have of ensuring that simple things that used to be simple things can be done in a safe way is really, really important. And they work very closely with the physiotherapists, the dietitians, and us, of course, and sometimes as well social workers as well. So social workers are a very important cog. They offer extra advice, financial help. They can signpost you to different support groups and help with providing care at home if that's what people need as well. There's another group of doctors, Sally, that I think we definitely need to mention. Some of my best friends are GPs, and our GP friends are legends. The thing about the public health sector that we work in, the NHS, is that unfortunately there has become a little bit of a disconnect between what we call primary care, GPs, and secondary care, hospital care. But good communication between doctors in these settings can really, really improve the care of our myeloma patients. And as people are living longer, so much more of the care is in the community. So to all our patients and my GP friends and all our GP colleagues that may be listening, we certainly think that we want to work even more closely with you and provide, seamless care, because so much care is happening in the community, and so much is coordinated from chronic symptom control to different ways of managing infection. For example, a lot of infections are looked after in the community, and even palliative care.
Obviously, GPs are integral to the health of all of us, and they hold an enormous amount of knowledge in their minds, and they apply that every single day. I think what can be so difficult sometimes about coming to see a specialist is it can feel like your specialist is just fixated on their one little tiny piece of the jigsaw, and sort of say, well, I don't deal with blood pressure, I don't do diabetes, I don't have an understanding of whatever it might be. You need to go and see your GP. And I wonder if sometimes that's interpreted as, well, come on, don't you know what you're talking about? Or why can't you help me? I'm sat here in front of you. But that is for good reason, because GPs kind of hold it all together. They hold an understanding of these illnesses together, but also of the patient together. And often if we as the specialists were to start dabbling in these areas, you wouldn't necessarily get the most up-to-date advice or care. But more importantly, it's really important that your GP knows about all these different areas and is referring to the appropriate specialists in that area if needed. So I think it's really important to emphasise that point, is that sometimes we do refer back to GPs, but it tends to be for very good reason indeed. And I hope that our GP colleagues are fully sighted on that as well.
I think over the last sort of 35 minutes, Sally, we've gone through the different layers of people that are involved, and at different times in people's journeys, different people will be at the fore. After treatment has taken place and people say are in a very stable situation, it may be an intense focus on physiotherapy to get people stronger and get their strength back. At the beginning, it's very chemo heavy, unfortunately, and there'll be a lot of doctors, a lot of pharmacists, and a lot of chemotherapy nurses. But there are different people and different layers of support for every part of the journey.
And always reach out. I would say, if you feel you have a particular need or your loved one does, just ask your specialist nurse, ask your doctor, or whichever member of the healthcare service you're coming into contact with. And more often than not, you'll have someone there who's willing, listening, and hopefully able to help or signpost you or refer you to the appropriate specialist.
Right, Sal, just to wrap up this pod, I think people might find it really interesting to understand how treatment decisions are made. And one of the real strengths of the NHS system in cancer, and I think this is really an exemplar way of making decisions in cancer care, is the MDT, the Multidisciplinary Team Meeting. So what is an MDT, Sally, and how does it work?
Yeah, so MDTs are sort of gold standard care, as you've said. The intention of an MDT is to make sure that the person and their condition is being considered in as well-rounded way as possible, with all the information that's available about that person being presented to the necessary experts in a room to pull all those pieces of the jigsaw I keep on referring to together to come up with a plan or a diagnosis in the first instance, and then a plan for that patient to take forward and to offer them or to share with them and see what they think about it. Clearly, it's not absolute. If the MDT suggests something, but the patient thinks that's not the right approach for them, then that is listened to. But it comes up with a plan based on the latest evidence and all the information that they have. And so we have these MDTs every week in most hospitals, where you discuss all cases, particularly people who are what we call newly diagnosed with myeloma, so they've just found out they've got myeloma, but also people who are progressing if they've been on some treatment for some time and things are changing. Those cases are often discussed as well. In addition to if someone's got some complaints, so you're not quite sure, could this be a problem with their bones? You might do an X-ray and want your colleagues to look at that, or you look at it all together. So that's really what the MDT does, and we take the decisions from the MDT back to the clinic.
And it's also a really important safety net. I think this should give patients a lot of confidence. When you're in an interaction with a doctor and they recommend X treatment, if you're not sure, or you think that doesn't sound quite right, it may be perfectly right. There may be a slightly different option. But the really good thing about the MDT is that you normally have a number of consultants sitting in there, and a rogue treatment approach or something completely unstandard will be called out and said, well, no, on what basis are you doing that? This is what should be done. So it offers accountability and ensures that safe treatment is offered, and I think it's very effective in doing that. So we're going to do a dummy patient. So this is not a real patient that we're going to discuss now. This is one we've just made up to really, I think, just give our listeners a little bit of an insight into maybe how decision making is made. Now, the best bit about this is, as I said, Sally's going to do a different voice for all the roles she's taking. So I'm playing myself, and Sally's playing a radiologist, a pathologist, a clinical nurse specialist, and we'll just do a little explanation. So I'm going to start, Sally. So are you ready?
I don't know which accents I'm going to do. I can't do this.
Hollywood awaits. You can just go around regional accents. Start Welsh, move to Midlands. No, I'm only kidding. Right. So, and actually, I had my MDT today. So our MDT day is Thursday. So we had our MDT today. Okay, I'm going to present Mrs. X. This is a 52-year-old lady who came to see me with a 2-month history of back pain. Her GP did her bloods, and her GP found that she was anemic with a hemoglobin of 90 grams per litre. She also had an X-ray done, which appeared to show some holes in her bones, some lytic lesions in the lumbar spine. She came to see me. She was in quite significant pain. And her bloods unfortunately showed a paraprotein of 20 grams per litre, an IgG kappa paraprotein with normal light chains. So I was concerned that this lady may have myeloma. So I organised a bone marrow biopsy and a PET CT scan. And I'd be grateful if we could review those investigations, please, and then come up with a diagnosis. So can we start with the pathology, please?
Certainly. So here we have the pathology results. So Mrs. X, and what I'm showing you here is a bone marrow trophine, or a sample of this patient's bone marrow architecture. And what you can see highlighted here in these stains is the abnormal cells, the plasma cells. And when I have examined this piece of bone, I can see that it amounts to approximately 70% of the cells. So that means that 70% of the whole cells in this piece of bone are myeloma or a type of cancer.
Thank you to the pathologist. So we've confirmed a diagnosis of myeloma on the marrow. Can we go to the radiology now? I think the plain films were quite convincing. So the lumbar x-rays were quite convincing for lytic lesions. Can we confirm, and can you show us what the PET-CT? I'd be grateful if you can show us the scan and where the abnormalities are.
Yeah, of course. Forgive the lack of accent, Jam. So what we have here is a PET-CT on Mrs. X, which was taken 2 weeks ago. And as you can see, looking at the images, there are areas which are lighting up or glowing, which corresponds to weakened areas of bones and lytic components within the bones. These abnormal areas exist within the lower part of the back, the lumbar area, the breastbone, and the upper parts of the limbs or the upper arms. So this would be consistent with widespread lytic lesions and the diagnosis of myeloma.
Are there any areas that are at risk of fracture that we need to speak to the surgeons about?
Not currently, but I would recommend further imaging of the lower part of the spine, the lumbar spine, perhaps with an MRI, just to assess how stable that spine is, and to ensure that braces or other interventions are needed.
Okay, thank you very much to our radiologist, who sounds remarkably like our pathologist. Mrs. X was in a lot of pain, so I started some painkillers and some morphine on her when I saw her 2 weeks ago. Can we just go to the specialist nurse? I know she's been in touch. Is her pain better? Has she got a sense that myeloma is the likely diagnosis? And what's her social situation? Can you remind us?
Yeah, so she's been struggling at home, actually. She's really been struggling with the pain relief. She's finding that she's struggling to go to the loo when she's on all the painkillers to take her pain away. So she popped in to see her GP last week and had some laxatives. But as a consequence of that, or because of that, she hasn't really been out of the house too much. So she's getting quite low in mood as well. So this is really playing on her mind. I think we need to see her in clinic as soon as possible to make sure that her tummy and her bowels are working properly, and also to provide some additional support for her at home.
Thank you very much. So I think we can confirm that this is unfortunately a diagnosis of symptomatic myeloma. We're still waiting for the genetic information on the bone marrow, which should come back in the next couple of weeks. But she's 53 years old. She's eligible for a stem cell transplant, so we should treat her in a standard way with a 4-drug combination of DVTD and strengthen her bones with bisphosphonates given once every month. Can we please make sure to our specialist nurse that she has a dental review before we do that? And can I check, are you in clinic tomorrow? Because I think she's coming back and we can confirm the diagnosis then and give her information on the chemotherapy. Yeah,
absolutely. I've asked her to attend tomorrow, and I've asked her family members to attend as well. So she's got someone with her when we talk about what may be necessary in the weeks ahead.
Okay, thanks very much. Does anyone else have any comments on the case, or are we happy to agree DVTD chemotherapy?
Agree.
Okay, thanks very much. Let's move to the next case. So that's broadly how we would say it. I think, Sally, you very kindly just used slightly simpler language than we would use when it's just fully doctors. But that's the essence of it, that you have someone presenting the information. You go to a pathologist, they will tell you what they have. You go to the radiologist, you ask the nurse what the situation is. You speak to your other colleagues. Everyone has a chance to comment. Now, sometimes there may be other people who come in. So, for example, a radiotherapy doctor may come in because sometimes we need to consider radiotherapy. There may be clinical trials team that join because there may be appropriate clinical trials for these patients. And in specific cases, other members of that allied health team that we talked about, for patients who have maybe very significant psychological problems, the psychiatrist may drop in for that 5 minutes on the case. In some places now, they do these completely remotely, like on Zoom or Microsoft Teams. But in some places, people still get together in a room, I think, which is quite nice, actually. But we do ours on Teams, and it works very well.
Yeah, we all get together, don't we? And the importantly, when you do it on your computer, you can still see all the images. And the pictures are actually really important because they really give you a sense of what's going on within that person. Yeah.
We discussed a relatively barn door diagnosis just now, but in some situations, what you find on biopsies or scans and even the clinical picture can be quite vague and unclear, and MDT discussion can be so helpful. And it's going to remain a crucial part of cancer care for decades ahead.
Indeed. And so I think there we are, Jam. Hey, I think hopefully to all our listeners, we've talked you through all the different individuals that you may encounter as part of, coming to treatment and living with myeloma. I hope, it's shed some light on all these different names and all these very confusing roles and actually what these people can do. But most importantly, I really hope for our listeners and their family members and their friends that knowing that such individuals exist may enable us all to speak up when extra help might be needed, no matter how big or how small, because more often than not, there's somebody out there who might be able to help.
Absolutely. I think that's such a lovely way to end this pod. Thank you to all our listeners for your company over the last 45 minutes. As previously, please let us know what you've enjoyed and what you'd like to hear more of. And this has been the Myeloma Minutes. We'll see you at the next one.
Farewell.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.